Hey guys, Miss Hill here, and this is individual module 4. This is our the concept of sexuality, PowerPoint 1, where we're going to talk about the concept of sexuality. So here are your learning outcomes listed there. You can read those. And let's get right into it. So when we talk about the concept of sexuality, we have to really understand what that means in the confines of how we take care of people as nurses. Sexuality contributes to healthy relationships of people. It contributes to their own sense of well-being as a human, as an individual. It's a very highly personal experience, and what sexuality means to an individual evolves from what types of experiences that they have had throughout their lifetime, from the time they were very small until that current point in their life. Sexuality is influenced by a lot of different things: physiologic experiences, psychological experiences, religious and cultural experiences. So how were you brought up? In what way do you live from a religious and cultural standpoint? And even through spirituality. There are no quote-unquote normal universal sexual behaviors. So that's important for you to understand from a nursing standpoint, so that you can be unbiased when you're taking care of people, just because their behaviors or the behaviors that you talk about with them are not the same as your own. Normal sexual behaviors are whatever gives mutual pleasure and satisfaction to the adults that are involved, as long as there is no threat of force or injury to that person or other people. So development also plays a role in sexuality. Sexuality begins at conception, and that continues and grows and develops throughout a person's lifespan. Nurses have to consider sexuality in a larger context of the development of the individual. So what are their experiences? Where are they developmentally in life? Where do they fall in the lifespan? From birth to 12 years, let's talk about how sexuality is apparent at this time in the lifespan. So several months after babies are born, they start to find their fingers and their toes, and they also find their genitals at the same time. And touching that brings pleasure to them, but it's not in a sexual manner. So it's not a sexual experience at this point whenever they're months old. By the age of 3 years old, they have a little more purposeful masturbation, so those touches are pleasurable in more of a sexual way, although they don't particularly understand that. And children at this age can have orgasmic responses, but boys do not have any ejaculate at this time. When children get to be between the ages of 9 and 10, we start to see physical changes in their body. So they begin to hit puberty. You begin to see changes of puberty. Girls get breast buds. That's called philarchy. Adrenal glands begin to mature in both boys and girls, and they produce testosterone and estrogen. And whenever you see children this age in a doctor's office, we rate them on something called Tanner stages. So there's a scale of sexual maturity rating that was developed by Tanner, and we give these children a stage of where they are on the Tanner model. Girls will show growth of breasts and pubic hair, and boys will show growth of their genitalia, and they will also start to develop pubic hair as well. And depending on how mature or how much of those things have happened to the child by that point, we'll assign them a Tanner stage. There's a chart in your book about that. And then we fall into early adolescence. So ages 12 to 13, you start to see primary and secondary sex characteristics will continue to develop. Primary characteristics are defined as your reproductive organs, and secondary characteristics are bodily traits that are influenced by a person's sex, but they're not involved in reproduction. So breast tissue, pubic hair, that kind of thing.
Batman.
Hey, Batman, will you take your Batman car to my bedroom? So that the people on my slide don't hear your Batman secrets. Okay, thanks.
But I don't want to take my car.
That's fine. Just go in my bedroom.
Because my car messed up. It's a thing.
Okay. We don't want to give away your Batman secrets. Okay. So in boys, sorry, that was Earl. So in boys, their testes and their scrotum start to increase in size. The skin over their scrotum will darken and their pubic hair continues to grow. And at this point, they start to become sweaty and stinky. Boys may have wet dreams. Their voice changes. They have a dramatic growth in height. So this is where you see boys really start to shoot up. But boys mature about 2 years later than girls. And the onset of puberty in boys is not as apparent as it is in girls, because girls begin menstruation. So that's an outward sign. Usually as a parent, you know when your girl has started menarche. And it's a time that you have to almost have that conversation with them regarding sexuality, but this is not as apparent in boys. So it's very easily overlooked, and boys tend to be a little more undereducated regarding sex and the sexual changes that happen in their body, because it's not as apparent. It's a hard conversation to have, particularly as a parent with your child. So sometimes boys get overlooked. So for girls, girls have a broadening of their pelvis and their hips. They have continued development of breast tissue and pubic hair. They also start to get sweaty and stinky at this point. Their vaginal secretions will change and become a more of a milky consistency. And those secretions will also change pH from an acidic kind of discharge now more to alkaline. When girls begin to develop breast tissue and start to have pubic hair changes, typically they will begin menarche within 2 years of that point. So that's an important thing for parents to know, so that they can be expecting this change to come, so that they can start educating their children. And same as for you as nurses. Menstruation in early adolescence may not be very regular to begin with. And typically in the United States, girls will start their periods around 12 years of age. But it's important to teach girls what the signs are of impending menstruation, because when it is not regular, they can end up with embarrassing accidents at school. So being able to recognize what it feels like or looks like whenever your period is going to start or before that period starts is important for adolescents to be able to recognize so they can be prepared and avoid embarrassment. And those are things like your breasts get tender, you might see more bloating than normal because your body's holding on to fluid. And the other thing that we really want to talk to girls about is toxic shock syndrome. Toxic shock syndrome is a rare and sometimes fatal condition. It's caused by toxins that are released from an overgrowth of Staphylococcus aureus. And a lot of the times you can get this from leaving a tampon in too long. And that's sort of the typical sense that we think about this being caused from. Signs and symptoms of that include nausea and vomiting, diarrhea, sudden high fever and chills. You may be dizzy, headaches, low blood pressure, conjunctivitis. And then another sort of very typical sign or sign that's associated with toxic shock syndrome is a sunburn-like rash and peeling of the skin on the hands and feet. If someone is diagnosed with toxic shock syndrome or they're having these signs and symptoms, they need to be immediately admitted to the hospital so those can be managed and prevent the shock piece of this from happening and hopefully save their life. Ways to prevent this are by washing your hands, changing your tampon every 4 to 8 hours, alternating between tampons and pads, using pads at nighttime, using tampons that are the lowest absorbency for that particular person's menstrual flow, and obviously keeping the genital area clean. So for girls, wiping front to back can help decrease this risk. It's important to teach girls who are early adolescents about these things so that they can avoid coming down with any of this. All right, so what about sexual experimentation? This is starting to occur earlier and earlier in the adolescent period. So earlier than in previous decades, which means we have to have these conversations with children earlier now than in decades past. And it's very important to be factual about the information that you give and non-judgmental. So we're going to focus on facts of the situation. We're not going to be judgmental about what they tell us or what they ask us, what they do or don't know. We're just going to give them the facts so that, and obviously talk to them all in terms that they understand as well. In young adulthood, the formation of intimate relationships start to happen. So a lot of the times these relationships are much more long-term. And with that also come implications of long-term relationships. So how are those relationships? How do they affect a person's day-to-day life? Young adults are often concerned about normal sexual responses. And it's really important for communication to be key in order for intimate relationships to be successful. In middle adulthood, there is a decrease in hormone production. Climacteric is the other term for this, and climacteric just means that it's a transitional period in the person's reproductive life. So we're having a decrease in hormone production for males and females. For men, they have a reduction in Leydig cells and androgen. but they do continue to make sperm. In women, they will start to experience perimenopause and eventually menopause, but women do not ovulate any longer. So whereas men continue to make sperm, women do not. Women become infertile, and men can stay fertile for up until old adulthood, and usually through their lifetime, actually. There may be changes associated with sexual self-concept and body image and sexual identity whenever you're taking care of middle adults. A lot of the times they start to have health problems at this point. They may have to have certain surgeries that you wouldn't expect in young adulthood or adolescence. And this can really take a toll on how they see themselves from a sexual standpoint. Many older adults continue to enjoy sex because now we live longer and healthier lives. Older women don't have to worry about pregnancy, so they can enjoy things without having to be fearful if they don't want to become pregnant, because it won't happen. And there is also much more availability for for treatment for sexual dysfunctions now than there were in the past. And society in general, particularly here in the United States, is much more accepting of sexual activity among older adults than we used to be. In men, they may need more time to achieve an erection and ejaculate. They probably will need more direct genital stimulation to achieve an erection, and their erections may be a little less firm, and the volume of what they ejaculate is probably going to be decreased. The intensity of their orgasms also may decrease, and they will have a longer period of time, a longer period of resolution in the sexual response cycle before they can achieve their next erection. And it is very common for men, older men, to experience erectile dysfunction at some point in their older adult life. For women, women remain capable of having multiple orgasms. They may experience an increased sexual desire after menopause, actually. But along with menopause comes decreased estrogen, which means we have decreased vaginal lubrication and less elasticity. So oftentimes older women will find that sex can be uncomfortable, and that's something we want to educate them about, how to make things better. Also, with women, just like with men, phases of the sexual response cycle might take a longer period of time. So in older adults, foreplay is more important than it is in the younger years, just because of age-related changes in the sexual response cycle. These guys continue to need emotional intimacy, and sometimes it's not always available to them because their partner has passed away. And intimacy can come in all different forms. It does not have to be sexual. You can have an intimate relationship with your pet, and I don't mean that in a sexual way. I mean that in a connective way. We can have intimate relationships with our friends. We can have intimate relationships with people in our church. So people that you have a close emotional connection with. And oftentimes older people begin to lose those people, those pets. They can't get out and go to places they enjoy where they've been able to make connections with people. So sometimes those things aren't always available to them, but it's a really important part of sexuality whenever you're an older adult. Common barriers to sexual expression in older adulthood can come from the loss of a partner or problems with their health status. So maybe they're not able to sexually express themselves anymore because their spouse has died, their partner has died, or maybe they have been diagnosed with diabetes and now they have a neurological problem and they are having difficulty maintaining an erection, or even having a pleasurable sensations because of neuropathy. The World Health Organization defines sexual health as physical, emotional, mental, and social well-being in relation to an individual's sexuality. This has to be positive and respectful in its approach to sexuality and sexual relationships. There has to be a possibility that sexual experiences are pleasurable and safe for the parties involved, and there needs to be respect, protection, and fulfillment of sexual rights of all individuals. And the World Health Organization goes further into defining what sexual rights mean. So individuals have the sexual right to have the right to sexual freedom, to sexual autonomy, integrity, privacy, and equity, the right to sexual and reproductive health care services, the right to sex education, and the right to make free and responsible reproductive choices for themselves. There are several components that we have to be aware of whenever we think about sexual health. And those are sexual self-concept, body image, gender identity, gender expression, and freedoms and responsibilities. So sexual self-concept is how the individual values him or herself as a sexual being. So who are you attracted to? Values about expressing your sexuality, the ability to freely choose your sexual partners. People who have a negative sexual self-concept may end up with a problem forming intimate relationships because that negative self-concept will hinder their ability to do that. Body image is exactly what it says. It's how an individual feels about his or her body, and people can see themselves in a positive or a negative light. And if you see yourself in a negative way concerning your body image, it can affect your sexual health. Gender identity is an individual's self-image as a female, a male, or a transgender person. It is very difficult to change gender identity once it is established in the person. It often lasts their life. Gender expression or gender role behavior is an outward expression of an individual's sense of maleness or femaleness and what is perceived as appropriate behavior for each gender. Oftentimes, this is defined by family and by cultural values. So how you see yourself as how you are supposed to act from a gender standpoint oftentimes comes from the values you learn from your family and from your culture. And there's a big extreme as well when we consider male and female, and some cultures see gender as not only two things, but as more than just male or female. Freedoms and responsibilities. This just means that people have the freedom and responsibility from a sexual standpoint to engage in activities that they choose. They can have free thoughts, feelings, and fantasies. but they also should be ethically motivated to exercise behavioral, emotional, and social responsibility for themselves and towards their partners and others. So, along with freedom comes responsibility. I say that to my kids all the time, not in terms of sexual health, but just in general. And that is the case really for any area in life, right? The more freedoms you have, the more responsibilities you have. So if you choose to be sexually free in whatever way you want to express that, as long as you are responsible about that, then the world should go round, right? So if you're a female and you want to have several sexual relationships and that's how you express yourself and that's part of your sexual health, then fine. But you also carry the responsibility of making sure that those sexual relationships are safe. So are you using protection? And if you don't want to have children, are you taking measures to prevent that from happening? That's part of the responsibility that comes along with sexual freedom. So what about culture? Culture affects everything in people's lives, but really it affects sexuality a lot, depending on what types of culture you come from. So an individual's sexuality is regulated, your book says to some degree, but I really think it is regulated a lot by your culture. So how you dress, rules about marriage, expectations of how you should act, and what your responsibilities are, what your sex practices look like, attitudes towards the various aspects of the human body. So some cultures find women who are a little more plump and juicy more attractive, and other cultures find women who are super skinny and bony more attractive. So where do you come from? It has to do with how we look at people. Dress and nudity. In some cultures, you as a woman, you can't show any skin at all. You have to stay covered up your whole face. You can only show your eyes. And in other cultures, nudity is completely and totally acceptable for women and common. There are also very controversial sexual practices that happen around the world, and specifically female circumcision or female genital mutilation is one of those. It's a common practice in Africa and some parts of the Middle East. But in some places in Africa and the Middle East, it has been outlawed because it is seen as a barbaric practice. What I will say is that you may come in contact with someone who has come from another country who has experienced female circumcision, and they may need medical care related to that, and it will also play a big role in how they see their sexual health. So just because this is not practiced in the United States, it is outlawed here, does not mean that you won't come across patients who've had this experience. Male circumcision is not seen as barbaric as female circumcision, particularly in Western culture, but the medical community has really said that this is really kind of a parent choice when children are born. There have been some studies that have shown male circumcision can be better for male health because it will reduce incidences of urinary tract infections. It can also reduce the likelihood you might get a sexually transmitted infection compared to someone who is not circumcised. So this is still practiced in places around the world. Male circumcision also has a cultural component, particularly in the Jewish community. It's really important that nurses not project their own cultural beliefs or preferences on other people that you are taking care of. And that really just goes without saying in any realm of nursing, not just with sexuality. Religion plays a big role in religious beliefs. There are guidelines in many religions for acceptable and prohibited sexual behaviors and consequences that might come along with those prohibited behaviors. So religion can be very detailed about what that means, about the rules of sexuality, or they can be very broad and flexible depending on the religion itself. Religious beliefs can conflict with the values of the larger society that you live in. And this can really create anxiety and sexual dysfunction in some people. And it can really create conflict within families. So I want you to think about this from a standpoint of where you live too. It doesn't necessarily just have to be you don't have to necessarily think of a country or a really large area whenever you're thinking about this, but think about certain pockets of the country. And one thing that really comes to my mind are homosexual communities. So there are lots of homosexual communities in San Francisco, but you don't find a lot of homosexual communities in Whiteville, North Carolina. So you think about the pocket of the place where you live too, and that will also depend on how society feels about different sexual practices and behaviors. If your sexual practice or your sexuality conflicts with the religion that you were brought up in, it conflicts with your family's beliefs about what sexuality should be, it can often cause major rifts in the family. And this is one reason why we find a large portion of adolescents and young adults who are homosexual or transgender or find themselves identifying with a different gender are homeless because their families have kicked them out. Personal expectations and ethics usually come from cultural norms. And it is very important for couples to explore and communicate really clearly about what they view as acceptable sexual expression, particularly if you are from different cultures. Couples should avoid domination in sexual decision making by one member or the other, because that will eventually lead to one party being dissatisfied with their sexual experience within that relationship. And the only way to take care of this is through communication. So what about sexuality and gender? Sexual orientation there are several definitions that we'll get into under the topic of sexuality and gender, and sexual orientation is one of those. So sexual orientation is a person's attraction to people of the same sex, the other sex, or both sexes. There is a continuum, and there is a really wide range between extremes of individuals that are exclusively heterosexual all the way to individuals that are exclusively homosexual. We also encounter people who consider themselves bisexual, so they are attracted to people of both genders. The origins of sexual orientation are not very well understood, and there are a lot of theories, but not many have some super solid scientific evidence one way or another, at least not spelled out in your book. There are biological theories that genetic makeup and composition contribute to people's sexual orientation. There are psychologic theories that people's early learning experiences and their cognitive processes play a role in their sexual orientation. And then there are other theories that believe that the environment that you live in combined with genetics create what your sexual orientation is. But a person's sexual orientation is very unlikely to change over a lifetime. It's enduring. There are many people who are uncomfortable disclosing their sexual orientation, particularly if they are not heterosexual, because they are at an increased risk for disparities in the healthcare system, access to care, and they're at an increased risk for certain health conditions and different types of behaviors as well. Conversion therapy is something that used to be performed on people who identified as not heterosexual. It is now outlawed in at least 4 U.S. states and the District of Columbia for minors. And there are plenty of other states in the U.S. that are considering outlawing conversion therapy for minors as well. Conversion therapy is not a scientifically founded therapy, and it actually is thought to cause more psychologic harm when performed, particularly on minors. So gender identity is different from sexual orientation because this is how you see yourself. So biologically, we have many gradations, or there's a continuum from male to female. What do you consider male and what do you consider female? That can differ. From a biological standpoint, about 1 in every 2,000 babies is born as an intersex person. There are chromosomal contributions to that. Their gonadal gender may not be outwardly apparent. Their internal sex organs may differ from what their external sex organs appear that they are. And sometimes intersex conditions are noticeable at birth, and sometimes they are not. Sometimes you don't ever know that someone is an intersex person because it's not detected until after they've died and the body has been autopsied. In other cases, we don't maybe realize that some people are intersex until it's time for them to hit puberty, and they don't. Or maybe they're a young adult and they have discovered that they're infertile because of this biological condition. And then transgender and transsexual are 2 different things. So transgender means that your gender identity and or your expression of that is different from the gender you were assigned at birth. Transsexual, on the other hand, are people who have changed or they are seeking to change their sexual anatomy through medical interventions. Gender dysphoria are strong and persistent feelings of discomfort with your assigned gender. But not all transgender individuals experience this distress, and some people who are part of the transgender, transsexual community, and some people who are not, do not see gender dysphoria as something that we should diagnose people with, I guess. So gender dysphoria is actually a psychological diagnosis, and their theory is that there is nothing wrong, because they don't all experience distress related to their gender. There are a lot of increased risks physically and emotionally to people who are transgender and transsexual, and that's important for you to remember as a nurse so that you can approach that topic with patients if the situation warrants. All right. Continuing on with varieties of sexualities, erotic preferences, and sexual lifestyle. Masturbation is a way for individuals to discover erotic feelings and learn about the sexual response cycle. And mutual masturbation can be shared with a partner and can be very, can help people really form intimacies with each other. There are all different types of erotic preferences and sexual lifestyles. There's oral genital sex, there's anal sex, genital intercourse, which is probably the most common for, most commonly what you're going to probably come across. There are other varieties of sexuality, and some of those are defined as disorders in the DSM-5 if there's an element of non-consent. So we've got one party that has not consented to that type of sexual preference. If anal intercourse is desired by couples, it should be coupled with some type of water-based lubricant, and the clients should be taught to always change condoms or wash penetrating devices or body parts before using those in other areas because of risk of infection. Okay, so the sexual response cycle is similar in women and men. Regardless of their sexual orientation, regardless of their motive for sexual activity, those phases are similar between genders. It starts in the brain, and there is some type of real or imagined stimuli that invokes sexual arousal for people. And then the 4 phases of that begin. So we have excitement, plateau, orgasm, and resolution. In the excitement phase, vasocongestion and myotonia happens, particularly in the genital area. So the penis becomes vasocongested as well as the clitoris for females. And we have this state of vasocongestion and arousal. During the plateau, women and men experience this very strong and prolonged sexual arousal. It can last just a little bit of time, or it can last as long as you want it to. Orgasm then is the involuntary climax of sexual tension and release, and this is sort of where people really measure their sexual response cycle. It is the height of the sexual response cycle. For women can have multiple orgasms that last from a few seconds to several seconds, and men typically are only capable of 1 orgasm in general. And then, of course, they have an ejaculate that happens during the orgasmic response, and their orgasms are typically shorter in duration than that of a female. Resolution is the period of time it takes an individual to return to an unaroused state. And that time frame can be different for different individuals. All right, so we talked about varieties of sexuality, the sexual response cycle, and now we're going to talk about alterations in the function of that cycle. So alterations in sexual function have to do with the ability to engage in sexual behavior that is important to most people. And there can be a gradient of problems that individuals experience with their ability to respond to sexual stimulation. Sometimes those problems can be generalized to all sexual interactions or settings, and then in other ways they might just be situational for specific settings or specific types of sexual activity. And these problems can often be related back to past or current factors that are affecting the ability to respond to sexual stimulation. It can take a variety of forms, and some of these can have a genetic component. So past and current factors that might interfere with sexual function for individuals can be sociocultural factors, psychologic factors, it can be even cognitive factors. So when we think of sociocultural factors, individuals who've had restrictive upbringings or inadequate sex education, they've been made to feel some type of punishment for doing what is developmentally normal and exploring their genitals or childhood sex play, which is normal from a developmental standpoint at certain ages. Religion and culture can play a part in this, as seeing sex only for procreation and not pleasure, so people feel guilty for getting pleasure out of sex, and then tend to avoid sexual acts. Rigid gender expression can also play a factor, and pressures of family and work even can play a factor in interfering with a normal sexual function. So, you work all day, you come home, you take care of kids, you're too tired to do it at the end of the day, right? All of these things from a socioculture standpoint can affect how people sexually function in their relationships. From a psychological standpoint, negative feelings can interfere with people's abilities to experience pleasure and joy. People can feel guilty from being excited about sex or participating in certain types of sexual activities. They can have anxiety because of previous sexual abuse or even current sexual abuse. People may be fearful of getting pregnant or getting a sexually transmitted disease. They might be fearful it's going to hurt. That's a big one with women who have recently had children. They are afraid that it's not going to feel the same or it's going to be painful. And many people just have a fear of being vulnerable and intimate with somebody else. Sexuality and sexual acts with other people are put people in a very vulnerable situation, and many people have a lot of trouble being vulnerable with other individuals and creating intimacy, because it's a self-protective measure to not be vulnerable and let yourself be that way. Okay. So what about cognitive factors? Well, cognitive factors are the internalization of negative expectations or beliefs about yourself, about your partner, about the situation. And not having accepted your sexual orientation or your gender identity can also be a cognitive factor that interferes with sexual function. Relationship problems are oftentimes a really big one that alters people's sexual function. So there is some type of conflict, anger, argument going on in the relationship. There is a loss of physical attraction for your partner. Maybe you become attracted to someone else and you compare your partner to that person. There's a failure to communicate what your desires are, what you want, what you don't want. Or there are disagreements about how often sexual encounters are going to happen, or what types of activities that you're going to do with your partner. And communication communication is the main key to fixing those types of problems, whether that be communication that you have with your partner alone and work out on your own, or whether that communication needs to be mediated by someone else, a sex therapist, a marriage counselor, or whatever. Internalization of negative expectations are things like, let's see if I can think of some examples here. Am I going to have an orgasm this time? Why do my legs look so big while I'm laying here? Why does my partner look fat tonight? So things that you're thinking in your mind cognitively that are negative thoughts that interfere with that sexual function or sexual experience that's going on right then at that time. That can take the pleasure out of what is supposed to be pleasurable. So alterations in manifestations. Physical health alterations can also interfere with sexuality because of chronic conditions like joint problems, diabetes, heart disease. So we have people with some type of restricted blood flow, and we can't get things working like we want them. They've got joint problems, so they can't move or get into position like they're used to, or it hurts. Maybe they have diabetes, and so we've got some neuropathy that's going on, and things aren't as pleasurable from a sensation standpoint. Maybe they've had surgery, and typically people who've had some type of life-altering surgery, like hysterectomy, counts in that, right? You're literally taking out a person's womanhood. Prostate surgery, people who end up with colostomies or amputations, all of those things can alter a person's body image and affect how they see themselves from a sexual standpoint. Spinal cord injuries, disfiguring surgeries or accidents, sexually transmitted infections can make people fearful or can interrupt their sexual life. Prescription meds also can have side effects that alter sexual functioning. So talking with your patients about medications that they may be on that can alter their sexual functioning is really important, educating them about that. There's a table in your book that talks about these different types of medications, and I encourage you to look over that. Alpha adrenergic blockers, ACE inhibitors, beta adrenergic blockers, all these blood pressure meds can put patients at risk for erectile dysfunction. They can decrease their sexual desire. Other drugs like amphetamines or cocaine can actually heighten the sexual response cycle, but these types of things also, along with alcohol and narcotics, put people at risk for unsafe sexual behavior because they lose their inhibitions whenever they're on those types of medications. Diuretics is another one that you don't typically think of, really, that can also decrease individuals' sexual desire. It can cause ED in men, and it can cause vaginal dryness and decreased lubrication in women. Dissatisfaction problems. This happens when an individual experiences a sexual desire, arousal, and an orgasm, but they still feel dissatisfied with the sexual relationship that they're in. So from a sexual response cycle standpoint, they can achieve all of the different parts of the sexual response cycle, but they still feel a dissatisfaction when that is over. A lot of the times, this is more often related to problems that happen in the relationship than problems that have to do with the physiologic response, because there's not an issue with the physiologic response. It's a lot of the times has to do with the relationship itself. And this really can be more disturbing than other types of sexual dysfunction, because here you are used to having sexual relations with, particularly if you're talking about a married couple, sexual relations with someone who you've been with for a very long time, and now all of a sudden that's not sexually satisfying for you anymore. So that can be really disturbing for couples. Dissatisfaction can include a lack of romance, love, tenderness, a feeling of being nurtured. And fulfillment of sexuality depends on the ability to relate to a partner in an intimate and a mutually pleasing manner that is compatible with that individual's values and their chosen lifestyle. So different sources related to dissatisfaction problems can be situational. It can be the timing of when your partner wants to have sexual relations. Maybe you're stressed, maybe you got a headache. There can be illness that it happens. There can be some type of trauma. There's an inability to communicate effectively, possibly some type of unresolved conflict between the couple, some type of rigid or unequal power in gender expression. So one person holds all of the sexual power in the relationship and another person feels like they have none. And potentially there may be a lack of intimacy or a lack of feeling of being connected with that individual, and that can affect your satisfaction with sexual experiences. Sexual dysfunction is more prevalent in women. Specifically, they have sexual interest and arousal disorders are what you find most common. And for men, what's most common is erectile dysfunction. There are lots of risk factors for altered sexual function, so altered body structure or function, trauma that happens, women who are pregnant, then they have there's childbirth, maybe an individual has genital abnormalities, a person maybe has comorbidities or diseases that alter their body structure or the way that they can function sexually. Abuse, sexual assault, things that disfigure people's condition, conditions that disfigure people's body image, medications that people might be taking, conflicts with their values, the loss of a partner, and the lack of knowledge or misinformation about sexual functioning or expression can also be a risk factor for having altered sexual functions as well. So, what about genetic considerations? Research for genetic considerations are kind of limited at this point, but there is some research that shows that there might be at least 2 genetic factors that are related to female sexual dysfunction symptoms. There are genetic markers that appear to be associated with erectile dysfunction in men also. And those genetic markers have also been associated through research with how effective treating erectile dysfunction from a pharmacologic standpoint will be. Just about every concept that you can think of relates back to sexuality. Culture and diversity, infection because of sexually transmitted diseases, perfusion for arousal disorders, reproduction, safety when it comes to keeping yourself safe from this sexual experiences standpoint, and trauma as well. Those are just a few, not an all-inclusive list. Okay, I'm going to take a break here, and I will record the last half of this lecture and post it up. So thanks for listening to part 1. Bye.